Hi, my name is Tisya Yadav, and I will be having a presentation on my research on mismatch repair deficient endometrial cancer. Mismatch repair deficiency has been found in about 30% of endometrial cancers and can cause several DNA mutations in cells, leading to cancer and affecting its progression. Mismatch repair deficiency is a loss of function in the mismatch repair pathway and causes mismatch mutations in the genome. Despite its prevalence, treatments for mismatch repair deficiency in endometrial cancer continue to remain obscure. Even with advancements in technology and immense research, mismatch repair deficiency in endometrial cancer continues to remain prevalent. While cancer is not hereditary, cancer-related genetic changes can be passed down from one's parents if present in their egg or sperm cells, increasing the risk for one to develop the cancer. Similarly, genetic changes that were inherited could cause mismatch repair deficient endometrial cancer. Mismatch repair deficiency is typically caused by mutations in the PMS2, MLH1, MSH2, or MSH6 genes, which are involved in correcting any errors made when DNA is copied before cell division begins. Mutations in any of these genes can cause proteins to lose their function, eliminating mismatch repair activity. The errors then continue to accumulate and disrupt the activity of other cells involved in controlling cell growth and division, which leads to development of tumors. To combat endometrial cancers with mismatch repair deficiency, immunotherapy, a treatment that triggers the immune system to fight cancer cells, has gained traction in the last couple of decades. In the treatment, drugs are provided to stimulate the natural defenses of the immune system, allowing it to target and attack cancer cells more efficiently. A common type of immunotherapy is checkpoint inhibitors, which are drugs that help the immune system identify and attack cancer cells, preventing the cancer cells from further replicating and accumulating. Another way the treatment could be done is by extracting immune cells from the tumor and cultivating them in a lab to insert intravenously in the human body and restore the immune system. Some antibodies include dostarlimab and pembrolizumab. Pembrolizumab, a drug that blocks PD-1 on T cells, allows these white blood cells that are part of the immune system to fight against the cancer cells. As immunotherapy becomes more vital to treat cancers, this presentation aims to address how mismatch repair deficient endometrial cancer reacts to immunotherapy treatments and affects the progression of the cancer. So now I'll be discussing the relationship between mismatch repair deficiency, mutations, and progression of endometrial cancer. A study conducted by Alina Fountsilas and her colleagues focused on the prognostic implications of mismatch repair deficiency in patients with non-metastatic colorectal and endometrial cancer. The Hellenic Cooperative Oncology Group helped identify patients with non-metastatic colorectal and non-metastatic endometrial cancer who would be able to help provide analysis tissue blocks. The tissue that was collected from the patients were the formalin-fixed paraffin-embedded tissue. The expression of the mismatch repair proteins MLH1, PMS2M, MSH2, and MSH6 were analyzed, and the intensity and percentage of each protein were recorded through immunochemistry. The expression of the mismatch repair protein was positive if more than 1% of the positive nuclei with an intensity ranging from mild to strong were counted. If the stromal cell and lymphocytic infiltrates were positive and the tumor cells were completely negative or were less than 1%, then the mismatch protein expression was considered negative. The expression was non-informative if both the tumor cells and internal controls were negative. Out of the 475 patients diagnosed with low-risk endometrial cancer, 131 were mismatch repair deficient and 344 were mismatch repair proficient. Those that were mismatch repair deficient had worse progression-free survival and higher recurrence rates than those who were mismatch repair proficient. Another study examines the relationship between POL mutations, checkpoint mutations, and mismatch repair deficient cancers. POL mutations cause polymerase proofreading associated polyposis syndrome, increasing the risk of developing polyps. Sequencing in this study was performed for POL on 202 endometrial cancers and immunohistochemistry. This study observed how POL mutations, mismatch repair deficient mutations, were associated with clinico-pathological features, checkpoint proteins, and density of tumor-infiltrating lymphocytes. The multiple mutations and mismatch repair deficiency caused elevated levels of tumor infiltrating lymphocytes. Also, a lower level of checkpoint proteins and higher levels of tumor infiltrating lymphocytes resulted with a better prognosis for those with endometrial cancers. And now I'll be moving on to the effects of antibodies on patients with deficient mismatch repair endometrial cancer. So, in a non-randomized phase 1 clinical trial, a study performed by Oknen and their colleagues investigated how dostarlimab, an antibody that binds to the PD-1 receptor, affected patients with deficient mismatch repair. The PD-1 receptor prevents the interaction with PD-L1 and PD-L2, stopping the anti-tumor immune response. The patients included in this trial were those who were 18 and older, were histologically and cytologically diagnosed with recurrent or advanced endometrial cancer, and had deficient mismatch repair tumors. For the treatment, patients were given 500 milligram infusions of dostarlimab every 3 weeks for 12 weeks. Then they were given 100 milligram infusions once every 6 weeks, which helped determine the anti-tumor activity of dostarlimab by calculating how many patients had a confirmed complete response or partial response to dostarlimab, and by the duration of the response, which was the time from the partial or complete response to the first sign of disease progression or death. Out of 71 of the patients, 9 patients had a confirmed complete response, while 21 patients had a confirmed partial response to dostarlimab. Another study led by O'Malley and their colleagues determined the safety of pembrolizumab in patients with advanced microsatellite instability high deficient mismatch repair endometrial cancer. In this non-randomized phase 2 studies, patients with endometrial cancer were placed in either cohort D, which had patients with advanced endometrial cancer, or cohort K, which had patients with any microsatellite instability high deficient mismatch repair advanced tumor, with the only exception for colorectal cancer. In order to be eligible, patients had to be 18 or older and documented metastatic or unresectable disease. The patients were given 200 milligrams of pembrolizumab intravenously every 3 weeks, 35 times. Overall, the pembrolizumab either maintained or improved health-related quality of life. Patients with a confirmed objective response had even greater improvements. And now for the discussion and significance of these studies. So these studies helped researchers understand the impact of mismatch repair deficient proteins on endometrial cancers, and they play a negative impact on the prognosis and progression of endometrial cancers. In the future, more of an emphasis on the prevention of mutations could decrease the mortality rates for those who are diagnosed with endometrial cancer. Antibodies, additionally, could potentially help patients with deficient mismatch repair endometrial cancer and reduce their symptoms. These drugs help prevent further progression of the cancer, even those who also had mismatch repair deficiency. As our understanding of endometrial cancer and mismatch repair deficiency continues to expand, less invasive treatments like immunotherapy could be utilized instead of chemotherapy. And these were my citations. Thank you so much.